Hello, my name is Dr. Jessica Walker. I'm an academic foundation doctor at City and Sandwell Hospitals, and today I'll be presenting an e-lecture on cataracts. Our learning outcome for today is to describe the typical clinical features and explain the management of cataracts. We will begin with what is a cataract. So a cataract is a clouding of the lens preventing clear vision. Although most cases of cataracts are related to the aging process, occasionally we can see cataracts in children or after eye injuries, inflammation or other eye disease, which we will explain about more later. Cataracts are a significant eye disease. They are labelled as the World Health Organization's priority eye disease due to the significant visual impairment and blindness they cause worldwide. Figures from 2010 say that 51% of the world's blindness can be attributed to cataracts. That equates to 20 million people. And the key thing is that this disproportionately affects lower socioeconomic regions because of the access to cataract surgeries in these countries. This can be seen in the above diagram, where you can see that across the world, the highest rates of cataract surgeries in dark blue are found in North America, Northern Europe and the UK, and also Australia and New Zealand. And the other areas across the globe have a much lower rate of cataract surgery despite housing a larger proportion of the world's population. So as I said, a cataract is the clouding of the lens. So what is the lens? The lens is a biconvex, avascular, non-innervated, encapsulated body. So you might be thinking, why am I saying all those technical words? I think these words really describe the function and features of a lens very well and help you apply it clinically. So firstly, the lens is biconvex. So you can see that it's got two rounded sides in an oval shape. And this, when you think of it being biconvex, this can remind you of the function of a lens, which is to take the light rays from the image in front of you, and the lens purpose is to focus those light rays on to the back of the retina so it can travel through the optic nerve to the brain and form a coherent picture so that the brain can see what's in front of you. Secondly, avascular. It doesn't have a blood supply. In fact, the fibres of the lens get their nutrient through vitreous humour, but that just reminds you that actually the lens doesn't regenerate itself. And that's important because actually in cataracts, our only option is surgery because cataracts just get worse and worse. There's no recovery from cataract progression. The third key point is that the lens is non-innervated. This is just helpful because it reminds you that actually the lens hasn't got a nervous supply, so it won't feel pain. So cataracts is a non-painful visual loss, which is really helpful when differentiating causes of visual loss. And finally, it's an encapsulated body. So it has a capsule surrounding the lens, which gives it that functionality of elasticity and being able to move, which we'll talk about on the next slide. I came across this illustration on Twitter actually, and I just thought it was a great picture illustrating the anatomy of the lens. So when we think of the lens and its structure, we can think of a peanut M&M chocolate with those three distinct layers. So we've got that outer capsule, the inner nucleus, which is a bit more soft like the chocolate, and then the hard peanut center, which is our nucleus. I'll now describe the layers in a little bit more detail. So we'll start with the capsule. So the capsule is the basement membrane of the lens, and it's made up of type 4 collagen. It creates this outer ring around the lens, which really gives it its structure, and it's quite stretchy as well. Attached to the capsule are these non-pigmented fibres, which you can see, these 4 fibres either side of the capsule. These are called the zonular fibres. These function to adjust the lens. Each side, they tug on the lens, increasing their tightness or relaxing, allowing the capsule to change shape. The process of these zonular fibres changing the shape of the lens between a more oval shape to a more rounded circular shape is so important in allowing the light to be directed onto the retina so that a picture is formed. And this process is called accommodation, the process where the lens moves to allow the light fibres to be pointed in the right direction to hit the retina at the macula and form the correct image for the brain to process the image and know what it is that you're seeing and that's in front of you. Then moving on to the nucleus and the cortex being outer, nucleus being inner. Even though in this picture they're depicted as 2 separate sections, histologically they are no different. They're both made of lens fibres, crystalline lens fibres, which are tightly packed in a perfect formation, which allows light to travel through them and the structure to remain transparent. The only difference, really, is that as you go deeper down, the lens fibres become more compact. When they become tightly compact and dense, this is what we call the nucleus, and this is why that area of the lens becomes a harder area. These crystalline fibres are made from epithelial cells which form a layer between the cortex and the capsule. These are active throughout life and continue to make more lens fibres which migrate from the capsule down into the nucleus, tighter and tighter. And this really gives you an indication and also a reason why cataracts form with aging. As more lens fibres are produced, the nucleus becomes denser and denser, and this is how cataract formation starts. But we'll discuss that on the next slide. There are 3 main types of cataracts. These are nuclear cataracts, cortical cataracts, and posterior capsular cataracts. We'll start with nuclear cataracts as these are the most common. Nuclear cataracts, also known as nuclear sclerosis, is the most common type of cataracts associated with aging. And its formation is as I described earlier, where as new crystalline fibres migrate down into the centre of lens, it becomes more and more compact. This reduces the transparency of the lens and causes a central opacification. Initially, when this cataract is formed, what you'll see as on this picture is a central opacification which can be cloudy white in colour. However, as the cataract matures and develops more, the fibres get tighter and tighter. The white dense material can actually change colour from white to yellow to orange and eventually can even become brown in colour. Key symptoms the patient might report is cloudiness to their central vision and also annoying glares, particularly at night. The next type of cataracts also associated with aging are cortical cataracts. These cataracts also form due to a disruption in the lens fibres, but whereas nuclear cataracts were due to a densening of the fibres, cortical cataracts can be when there is a dislodged fibre which causes a spoke-like appearance, as you can see in this diagram with the wedge-shaped cataracts from the iris poking inwards. These cataracts form more superficially in the lens, so more in the cortical area as opposed to the nucleus. These can often be left unnoticed by the patient for a lot longer because, as you can see in the diagram, the centre of the lens is left untouched. So since it doesn't affect the visual axis of the patient, they often don't notice the difference. And our third and final type of cataracts we'll talk about today is posterior capsular cataracts. These can occur in younger people and tend to be associated with inflammation to the eye. Metabolic or inflammatory systemic diseases, all localized to the eye, including diabetes and uveitis, can affect the posterior capsule of the eye and also cause more epithelial cells to congregate in the posterior aspect of the cortex just next to the capsule, and this causes these smaller opacifications. As well as being associated with systemic disease, they can be spontaneous, so they're another type of cataract to look out for in all people. The risk factors for cataracts we've touched upon, but to summarise, they are elderly people above age 65. Whenever you have someone with visual loss above 65, you can always think of cataracts as one of your differential. Other things are trauma, because whenever something hits the eye that causes an effect on the crystalline fibres, this could cause a cataract, so always think about trauma and cataracts. Steroid use, smoking, diabetes and UV light are all other risk factors for cataracts. Gradual painless loss of vision. I think that's a key phrase I would try and remember for cataracts really. That really sets it apart from other differentials. So it's gradual, it doesn't occur overnight. This is an aging process. This is a gradual process where fibres are being built up. Patients won't go to bed one night and wake up the next day with the cataracts. So anything that's gradual, you can always have cataracts as your differential. Painless, again, because we said the lens is not innervated, so this doesn't cause the patient any pain. So what this might be described as by the patient: difficulties with reading. That opacification means they can't focus on the words in front of them. Can't see the words in front of them. Failure to recognise faces, because actually this is kind of a clouding of the lens, so they might still be able to see the person, but pinpointing the face, seeing the actual distinct features of that person's face might be difficult for them. And again, this will affect them watching TV. Another thing is diplopia in one eye. The way we test diplopia, if it's one eye, so monocular, versus two eyes, which is binocular, is to ask them to cover one eye. If the diplopia, the double vision, is still present with one eye covered, then we know it's monocular in one eye and it's a problem in the eye, an ophthalmological condition, as opposed to binocular double vision, which is usually a neurological and brain issue. Halos. So they get both diplopia and halos, which is where you get kind of a bright white circle because of the scattering of the light when the lens fibers are disrupted. So the key signs for cataracts. The firstly is seeing opacities on the red reflex. So the way you perform the red reflex is you stand 60 centimeters from the patient, you take your fundoscope and you shine the light through their pupil. What you expect to see is their pupil becomes red as the light bounces on the retina and reflects back at you. Similar to the red eye you see when you on a flash when you use a camera. But what happens in cataracts is, firstly, there might be no red reflex. It might just be white or brown, which is a mature cataract. There's no light getting through there. But you might just see that there's some black dots, or there's a central opacification in nucleus sclerosis, or you might see the spikes of the cortex, and this indicates a cataract's presence. So have a Google for some red reflex images. Another thing is that you might even see, without shining in the light, that the person's lens is just brown or white or orangey colour, all indicating a cataract is present. Moving on to differentials. A tip for med school in general is, whenever you've got a presenting complaint, always have a few differentials in the back of your head so you can tailor your history, whether it's abdo pain, chest pain, think what things can cause these. And the same with vision loss. So a few differentials you could have for cataracts. Age-related macular degeneration. It's a good differential because it also occurs in increasing age. It can be gradual, but key differences are that macular degeneration tends to affect nighttime vision, whereas often cataracts can improve in low light, and you can get more bursts of sudden vision, particularly in wet AMD, but I'll leave you to look into these diseases in more detail. Another thing is retinal disease. For example, diabetic retinopathy can also affect the vision in a painless way because it's at the back of the eye. You can get hemorrhages, but you tend to see more of floaters and part of the visions that are obscure, as opposed to cataracts, which is this general cloudiness of vision. And another key one is presbyopia, but more in general, just refractive error. As people age, their lens becomes, their lens capsule becomes less taut because the zonular fibres have relaxed, as we talked about earlier. So they struggle to accommodate and see and read their books. This is just part of aging, and actually a treatment for this is reading glasses. A way you can test for this is by doing corrected visual acuity. So when you do corrected visual acuity, it takes into account any refractive errors, and their visual acuity should go back to their baseline. When we approach management of diseases, it's always important to use a structure. A structure I'd recommend is looking at conservative management versus medical management versus surgical management, and that's your escalation of management. So in cataracts, our conservative management is watch and wait. We can watch to see what happens to the cataracts. It might be that somebody can live with their cataracts, particularly if it's a cortical cataract and just affecting the peripheries of their vision. However, if it is deteriorating, there unfortunately isn't any medical management for cataracts. As I said, they just progress. There's nothing you can do about them, like no drops or anything. So actually our mainstay of treatment for cataracts is surgical management. The type of surgical intervention that's used is extracapsular lens extraction. There are two here that I've listed, but we'll start with number 2, phacoemulsification. This is by far the most commonly used surgical intervention for cataracts. It's a very nice surgery. Actually, I'd recommend you go to a theatre and ask to see a cataract because it's really impressive. But effectively, what they do is they make a small incision into the cornea, a couple of millimetres at most, into the cornea. They then insert an ultrasound probe into the capsule, and they emit high intensity ultrasound waves, which breaks down the cataracts, which breaks down the lens into little pieces. They then take a suction and pull out all these remnants and remove the cataracts. And then finally, they reinsert a foldable lens. They pop it into the capsule, and then it folds out. And there you go. You've got a new prosthetic intraocular lens in place of the cataract. Your other option is conventional extracapsular cataract extraction, Why would you do this? Well, in very mature cataracts, which are very rigid, very hard, you're not going to be able to destroy them with the ultrasound probe, and even if you do, they might cause damage to the capsule and the eye. So actually, it's safer to do a wider incision and remove the cataract out as one whole entity. This obviously has more surgical complications in terms of you need a larger incision, so in turn you need more sutures, whereas in phacoemulsification you might need one or usually no sutures. Again, if you can't make theatre, it might be good to have a look at these on YouTube so you can visualise what they're actually doing. But hopefully this gives you a kind of a summary of them. So these are the 2 surgical interventions you need to know. The other type, intracapsular lens extraction, is not really used anymore. With all operations and procedures we perform or we consent for, we need to know the risks. And there are a few that are important in this. So to go through them, edema of the cornea, so the front of the eye can become swollen. There could be a rise in intraocular pressure, so you've put a new foreign body into the eye. This can cause increased intraocular pressure, which will need to be treated, otherwise it could lead on to optic nerve head damage and glaucoma. Uveitis is inflammation of the layer of eye tissue that includes the iris. Infection of the external eye. This could be minor and use topical antibiotics, or if it affects the whole eye, endophthalmitis. This can be very serious, needing severe intense antibiotics, and in worst case scenarios, removal of the entire orbit. Hyphemia you can see in this picture, so this is a collection of the blood inside the anterior chamber of the eye. It usually self-resolves, it's very common, it occurs in the first 2 to 3 days. You can get leakage or rupture of the incision where you've inserted the cataracts. You can get retinal detachment or tear, so the retina on the back of the eye, which is very important. If you get detachment or tear, it requires urgent intervention. Because it's a sight-threatening complication. Malpositioning of the intraocular lens if it's not quite in the right place. And cystoid macular edema. This is one to know about. It's where, because you've been doing the operation, fluid can accumulate in the layers of the eyes and accumulates in the macula at the back of the eye. This can cause blurring or distortion of the central vision. It rarely causes long-term sight loss, but it can take two months to 2 years for the edema to resolve itself and the person to go back to normal vision. So in conclusion, cataracts is a common cause of visual impairment in the aging population. The biggest risk factor is age, but you need to be aware that other things can increase and accelerate cataracts formation, including diabetes, UV light trauma. Cataracts are reversible with surgical management, and our mainstay of treatment is phacoemulsification. But it's very important to note that if after cataracts operation the patient does not return to normal or improved sight, then we firstly need to look for complications. Could there be a development of cystoid macular edema? Could there be a retinal detachment? All of these will require urgent ophthalmology review. Additionally, is there a pre-existing condition to the eye, particularly a retinal pathology? When a cataract's in place and it's mature, the ophthalmologist can't see to the back of the eye because they can't see through the lens. So they might remove the lens and find out actually this person's got really bad diabetic retinopathy at the back of the eye, and then we'll need to start treating and managing for that. So this is the summary of cataracts, their clinical features and their management. Thank you for listening. If you have any further questions about cataracts, ophthalmology, or any other ophthalmological questions, please drop me an email on jessica.walker34@nhs.net. These are my references and also just good guides for a little bit more detail. And I'd also suggest watching a video of the cataract procedure or attending theatre during your ophthalmology placement. Thank you for listening. Goodbye.